Okay, thank you everybody for joining us for tonight's update on screening for colorectal cancer in partnership with St George Hospital. My name is Bertha Harvey and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. I would like to acknowledge the Aboriginal and Torres Strait Islander people of this nation. We acknowledge the traditional custodians and sovereign people of the land across which we work, and we recognise a continuing connection to land, water and community, and pay respects to elders past, present and emerging. GP can share. If you are not aware of it, this is a great service which aims to strengthen integration between cancer specialists, community services and GPs. Jeremy's contact details are on the screen, and he is based at St George Hospital, so there's more information on that coming through. And I will hand over to Jan, who will just talk about the GP Workforce Planning Survey.
Thanks, Bertha. I really appreciate, I'm not going to take too much time because I know it's an exciting topic tonight. And thank you for letting me crash your meeting tonight. And I apologise if some of you GPs have already heard me go over this. But as you probably know, GP Synergy has been the training organisation for GP registrars over the past years. And you would know that this is not the case now, and that RACGP and ACRM have taken on this role. The Commonwealth Department have engaged primary health networks to help provide independent evidence-based recommendations to inform the geographic distribution and placement of registrars, so as to meet the community's current and future GP workforce needs. So we have a survey, and I know we're all done with surveys, but this is the way we can gather some information and help you out there. It's been developed by the lead organisation for this project for New South Wales ACT PHN. And this survey can be filled out by a GP registrar, a practice manager or a practice nurse. And this wide spread of health professionals means that we can gain a good insight into the GP workforce and any issues out there. Your input will help us understand the enablers and what helps and supports the workforce, and also any barriers that might come up. We would also be interested in any possible solutions to current and emerging workforce needs, and I'm sure there's lots out there, and shortages that you might be experiencing. There is the option to complete the survey via a QR code, and that you can use this with your phone, or there'll be a link that you can do it on a computer. We as the PHN don't really have a say in the placements of the registrars, but the more information and feedback that you can give us will help inform the colleges of any workforce needs out there. So it's really important that we get this information in. We really need you to fill it out so we can inform the Department of Health, RACGP and ACRM of any needs in the area and local needs. And that could mean, you know, what's happening in your general practice, what's happening in your local area. You know, it could be environment, it could be social, it could be, you know, just lack of GPs in the region. So, and information on the training capacity in our region also, especially around GP registrars. So you'll have the opportunity at the end of the survey to add your name also to participate in further consultation on this, either by a focus group or one-on-one, face-to-face, phone or online. So this is also to gather further information on your experiences as GPs or GP supervisors or GP registrars. And you can also contact myself at the PHN if you'd like to participate in further conversation. My email and phone number will be on the flyer that we'll be sending out to you after tonight. So appreciate your time. Thank you very much to the working group for letting me speak tonight. And that's it. Thank you.
Thanks, Jan. And we will now get started. And I'd like to introduce Kristine, who's a gastroenterologist CNC, and Dr. Pavan, who is a gastroenterologist at St George Hospital. Thank you.
Thanks, Bertha. Thank you, Jan. Thank you, Martina, Kylie, and the Integrated Care Chronic Diseases Working Party for asking us to speak. Kristine, do you want to share your screen? Because we might run off your computer. What do you think? Probably works the best. I'll just have to tell you to advance slides as we're going. Look, while Kristine gets the talk loaded, I want this session to be interactive. Having done quite a few GP talks, I think the best part of this type of talk is the interaction. So I want all of you online to be active on the Q&A box. I've got it open on the screen above me. So Kristine and I are both happy to answer questions as we're going. Unfortunately, Kristine can't see the Q&A questions because we're sharing her screen, but I'll be able to see them and we can kind of answer them together as we go. So please put the questions up as we're going, and we've purposely left a lot of time at the end for questions. Look, I might introduce Kristine. A lot of you will know me from the 12, 13, 14 years now. I've been at St. George in the gastroenterology department, running the gastroenterology clinic, as well as the IBD clinic, as well as other various different hats I've had. Kristine was one of our ward nurses and was exceptional in that role, and transitioned into this CNC role a few years ago, and has done an amazing job, and actually has interacted with a lot of you. I suspect you would know of her name on the bottom of signatures, but you may not have ever met her, and we're incredibly lucky to have her. She does an amazing job, and actually functions very much like a junior registrar in our department, and really does an amazing job coordinating a lot of this to do with colorectal cancer screening, polyp surveillance, but also following up results after colonoscopy, getting them back to you and the patient. So you'll be hearing a lot from Kristine later. So look, I might move to the next slide, Kristine. Look, again, I've mentioned this group already, an amazing group who also do an amazing job in really trying to bridge the gap between primary and tertiary level care, and really contribute on both at both levels to that, both at our hospital and other tertiary institutions, but also at primary care level. Kristine, we might move to the next screen. So look, what we're going to try and cover today is screening of patients with colorectal cancer, with a family history of colorectal cancer. There's been the guidelines have changed recently. So around family history, the guidelines changed a few years ago, and you may not be aware of that. Secondly, we're going to talk about polyp surveillance. And again, the guidelines around this have changed. And there are new guidelines around polyp surveillance. Not only that, Medicare and the government have moved to link colonoscopy item numbers to these guidelines, and hence will not pay for procedures that are outside of these guidelines. So they affect all of us, and you need to be very aware of that, because often it's all of you that are talking to the patients firsthand, explaining polyp surveillance and or family history intervals, and when they're not tied to these guidelines, it can make it very difficult for us to convey something. Sometimes it may be a different message to what has been said to the patient at primary care, and it's good for us to be on the same page. That doesn't mean you need to know the guidelines. You need to have an understanding of them to help in the referral, because if we're not on the same page, sometimes it can make explaining why a patient doesn't need a colonoscopy right now difficult for both Kristine and I. Hey, there's a question that's here. I'm happy to quickly take it now, or I might leave it actually, because it's very specific about a specific case. So I'll leave that, and I'll promise I'll answer that, but we'll come back to it. Then we've got some cases, and then we'll discuss around that, and some of the things you've put in that question, Kristine's going to cover in some of the case discussions we're about to have later. And lastly, you may or may not be aware that the Ministry of Health are rolling out a series of statewide referral criteria. So gastroenterology and ophthalmology happen to be first cabs off the rank, but this is going to be rolled out across every tertiary level specialty clinic in a public hospital. So it's going to affect all of you in terms of referral to clinic and other clinics as well. The gastroenterology statewide referral goes live very soon, actually. We don't know exactly. They haven't told us an exact date. Is that right, Kristine? Nod for me if that's still the case.
Yeah, there's no go live date just yet, but we are working towards it.
Yeah, so we'll talk briefly about that at the end. Next slide. So what I'd like you, at the end of this session, we'd love you to have a good understanding of the current screening guidelines for family history. We don't want you to know it, just want you to have some kind of understanding of it to help guide your referrals and your communication with your patients. Also, equally, we'd like you to have some understanding of polyp surveillance guidelines. And again, it doesn't have, when you see the tables that Kristine and I present, they are quite complex. We don't want you to know those tables. We want you to understand the principles behind those tables so that when we use those guidelines, it makes sense to you why we may or may not be doing a colonoscopy at this time versus this time versus this time, and hopefully help you in terms of referring patients to us. Okay, next slide. So we're going to talk firstly about family history, and then we'll talk about polyp surveillance. So that we've got some cases and some examples. So this is a real case. So we've used some cases that have been referred to the clinic over the last few years. So 58-year-old female who has a family history of colorectal cancer. She's completely asymptomatic. She has one first-degree relative diagnosed with colorectal cancer at the age of 75. Never had a colonoscopy before and has participated in the National Bowel Cancer Screening Program in 2021, so the 2 years ago, and it's negative. And I might just stop 1 second. If people want to pop things in the Q&A about what they think of that family history and what is really important in that family history. And then I'll move to the poll. But if nothing's coming up, I'm going to move to the poll. I think that let's move to the poll because we'll have plenty of time for discussion at the end. So would you, in this case, should this lady have a colonoscopy now? Should it be every 5 years from the age of 65? Should she have an FOBT every 2 years, i.e. she had one in 2021, or should she have her next one in 2023? Or does she not need any form of screening? So we'd love you to answer those. And if you want the clinical details, I'm happy to go back to the last slide if it doesn't throw Bertha out of whack with the poll. If we move back to slide, Bertha, does it change the poll, or will the poll still be live? So
it will still be live. Yeah.
Oh, fantastic.
Yep.
Go back one, Kristine, so they can see the clinical details. Yeah, so that's good answer from Catherine. 58-year-old lady. Family history is relevant, but she's also had a normal bowel screen. So you're going for repeat bowel screen. Now, can we see people's votes yet? Is there a live poll somewhere? Oh, fantastic. Excellent. So a third of you feel colonoscopy now, maybe 20% think every 5 years from the age of 65, and then 49% are kind of favouring FOBT in 2 years, i.e. she had one 2 years ago, and it's usually a 2-yearly cycle. And then thankfully, none of you are saying she doesn't need any screening at all, which is definitely not correct. So that's good. That's good that no one's picked that option. This is probably the perfect time to hand over to Kristine. I won't tell you what the answer is. I'll let Kristine talk you through this because she is our direct access colonoscopy nurse, as I mentioned at the start. So she looks after a lot of direct access without symptoms. So family history of colorectal cancer or polyp surveillance, but also follows up a lot of these patients. Kristine, I'll hand over to you, boss.
Thanks, Gok. So as Gok mentioned very early on, there has been some changes made in the recent years to the risk classifications and the screening guidelines for patients with a family history of colorectal cancer. So it is important to note when assessing a patient's risk that all the components, if possible, should be taken into consideration. So including things like any genetic syndromes, the number of relatives diagnosed, and their respective ages. So just knowing that there is a family history is probably not going to be a strong enough indicator of the patient's risk level. So the 3 categories that we have here at the moment, Cat 1 is defined as having 1 relative diagnosed at the age of 55 or older. Category 2, 1 relative with colorectal cancer diagnosed before the age of 55, or 2 relatives diagnosed at any age. So first-degree relatives diagnosed at any age, or 1 first-degree relative and at least 2 second-degree relatives diagnosed at any age. And then to category 3, which signifies a 10-fold increase in the average risk. So having at least 3 first-degree relatives or second-degree relatives diagnosed with at least 1 before the age of 55, or at least 3 first-degree relatives diagnosed at any age.
Christina, can you go back 1 slide just to that slide you're talking about? I just wanted to highlight the age. So colorectal cancer is a very, very common cancer, and hence a family history becomes super significant if the relative, so the general principles of this table are age, so a young person's, that the index case being young is really important, and first degree versus second degree is really important. And the third point is the number of relatives is really important. And you can see an easy way to remember category 3 is 3 relatives. So either 3 first degree and second degree relatives, but 1 before the age of 55, or 3 first degree relatives full stop. So easy to remember 55 in your heads. And then easy to remember kind of if you have 3 relatives, then you're almost automatically in category 3. Sorry to interrupt you.
That's all right. So these are the recommended screening strategies for each category. So category 1 recommends an FOBT every 2 years from 45. Category 2, FOBT from 40 to 50. Then a colonoscopy can be done every 5 years from the age of 50 to 74. And category 3, an FOBT every 2 years from 35 to 45, then 5-yearly colonoscopies from then. And also to consider referring to a genetic centre for some further testing for any hereditary cancer syndromes needs to be considered. And all of these recommendations for the 5-yearly colonoscopies is assuming that the index colonoscopy was normal. So if there were any polyps present at those colonoscopies, then we would then need to refer to the clinical practice guidelines for polyp surveillance.
So some of you would know the old family history guidelines. In fact, a lot of you will know the old ones. But this is markedly different. So you all need to be aware of that. There's been a push away from too many colonoscopies being performed in young people unnecessarily at times. And you can see that these guidelines are a little bit more, I guess, less invasive, really pushing for FOBT in those that are young and holding back colonoscopy until you're a bit older. Whereas previously you had that 10 years before the index case, you're up for a colonoscopy kind of in the guidelines. So there is a kind of change in the guidelines that you need to be aware of. And it's quite striking when you look at this versus the older ones.
So for this case study, which a majority of you did choose recommendation C. So SC is a category 1 risk level. So the recommendation is to do an FOBT every 2 years. So her last FOBT with the National Bowel Cancer Screening was in 2021. She's due to have another one done this year, and depending on the results, that will determine if she needs a colonoscopy or not. So again, this does highlight the importance of assessing all the aspects of their family history, including the age at diagnosis. So even though it is a first degree relative, if her mum was diagnosed under the age of 55, she would fall into a different category, category 2, which has a different recommended screening strategy.
Kristine, this might be a good time to answer the question that's on the screen, if that's okay. Is that all right? There's a question, you can't see it, so I'll read it out and we'll answer it together. 70-year-old mother has a recent colonoscopy. I know the audience can see the Q&A poll, so you can read with me. She had 7 polyps, out of which 2 were serrated adenomas and 1 was a tubular adenoma with high-grade dysplasia. When should her children and siblings start having colonoscopy? So that is an excellent question. And the guidelines around screening for family history of advanced adenoma or a family history of advanced adenomas is less clear. There are no guidelines really to help us with a family history of advanced adenoma versus family history of colorectal cancer, which is what we're talking about. Whereas the question on the screen is asking about a family history of an advanced adenoma. Now, that's very much case by case. And again, age comes into it. So for me, a very young advanced adenoma, say a 40-year-old with that many polyps, or a 40-year-old with a 30-centimeter large advanced 30 millimeter advanced adenoma, or 3-centimeter advanced adenoma, then you may consider, and the guidelines, again, there are no firm guidelines, but there is some evidence that maybe they should have a colonoscopy. But that is a very soft recommendation, and it should be case by case. So we generally shouldn't just be doing colonoscopy for a family history of adenoma unless it's a particularly striking case, like multiple adenomas or one really big one in a very young person. Excellent question about FOBT positivity. So FOBT positivity is about 60% or so. Are there newer, more sensitive tests, and are they likely to be in the future? So that's one of the risks with, so the IFOBT sensitivity is slightly better than that, slightly better than 60. It is better than 60%, but your point is very valid that if we're relying so much on FOBT, are we going to miss cancers in this group with a family history? And the answer to that is usually it's kind of age that kind of determines, probably the strongest determinant of risk, which is why they've held off colonoscopy even in the category 3s until they're a little bit older. And then if you find polyps on your index colonoscopy, the rest of your surveillance going forward is guided by that colonoscopy. And hence we're kind of moving away from this automatic kind of 5-yearly thing, because your first colonoscopy should be what guides the future ones. Sorry, Kristine, I wanted to answer the question that came up.
All good. So we have another case study, and this is another case that has come through direct access. So a 46-year-old female also presents with her family history of colorectal cancer. She has 2 relatives, one being her mother, who was diagnosed at 42 years old, and also her maternal grandfather, who had passed away from colorectal cancer at 64. She also reports some PR bleeding, no other red flag symptoms, and she has never done a colonoscopy before or an FOBT. So I thought that we could use this and open up some discussion here if anyone has any comments on the current guidelines or wants to talk us through what would be the most appropriate way to manage this case.
Just to remind you, this lady is 46. Mother, so first degree relative, had cancer age 42. And there's a second degree relative who's a bit older. And she has some PR bleeding and has never had a colonoscopy before. So sorry, Kristine, go to the next slide. And
yeah, all good.
People want to talk through the next one. There's a comment about colonoscopy now.
Mm-hmm.
So which category does she fall into?
So she would fall into...
What does the group think? Any live answers? Yep. There's a category 2 vote. Any other votes up there? Oh, lots of category 2s flying in.
Perfect.
Yeah, that is where she falls. Kristine, I'll hand over to you. Sorry.
No, all good. That is right. She does fall into category 2. Her first degree relative, her mum, diagnosed before the age of 55. So she would definitely fit into category 2. When we look at the screening recommendations, the recommendation is to do an FOBT every 2 years from the age of 40 to 50, and then perform a colonoscopy every 5 years from the age of 50 to 74, assuming that her index colonoscopy was normal.
So this is an excellent example. Go back one slide, Kristine. This is an excellent example of where the guideline change has been very significant, because people who said colonoscopy now, the old guidelines would have said, yeah, well, the index case was 42. This lady is greater than 10 years younger. She's older than 32. She should have a colonoscopy. So that's where the change has really been pushing to delay colonoscopy until they're 50 in this category 2 age group. Sorry, Kristine.
Oh, good. So another multiple choice. What would you do now? A, colonoscopy now, FOBT now, then every 2 years. Doesn't need any form of screening or specialist referral for assessment of symptoms.
There's some very good points up here that we're going to talk about in a minute. So, Kristine, doesn't she have PR bleeding? Therefore, shouldn't she have colonoscopy now? If she has PR bleeding, she needs a scope. She has symptoms, so no longer screening. So there's a few people going colonoscopy now, some people going FOBT every 2 years. No one's gone, doesn't need any form of screening, which is fantastic. And a lot of people have, 20% have asked for specialist referral for assessment of symptoms.
So for this case, we would probably choose D, refer to a gastroenterologist for investigation of PR bleeding. So the screening guidelines don't apply for patients who are symptomatic, but in this case, she did present for her family history. So we would definitely discuss the guidelines with her for future management. But of course, she will need those symptoms investigated first. But for future, after her investigations, for future management, we would recommend to do an FOBT every 2 years until she is 50, and then a colonoscopy every 5 years from then.
For those of you that said colonoscopy now because she's got rectal bleeding, it's very, very valid. However, there are things that patients report that is sometimes not always that straightforward. And also within the public hospital system, we also need to even triage within the category 1s, if that makes sense. So we have 3 categories, as you know, category 1 colonoscopy, category 2, category 3. And the category 1 colonoscopy, technically, the New South Wales Health Guidelines have that 30-day box. But as most of you know, in reality, at every public hospital in New South Wales, if you tick the 30-day box, it generally doesn't happen within 30 days because of the resources that are available. And you all know that because there are this many patients needing colonoscopy and there are this many spots available on lists, or there are this many resources to perform that colonoscopy. So even within those patients that are deemed category 1, which rectal bleeding usually is, we need to be able to even re-triage that category 1 with what type of rectal bleeding. Does it sound hemorrhoidal or not? Does it sound, do they have associated symptoms? Do they have change in bowel habit and other things that make them even higher in the category 1? Because as most of you know, all of us bend over backwards to make sure that the patient that whose symptoms are strongly suggestive of colorectal cancer gets a scope definitely within 30 days. Because if we tick the 30-day box and hand it into admissions, it won't happen within 30 days. So that patient, all of us, when we're in clinic, make an effort to get them done within 2 weeks, if possible, or 3 weeks, or not the type of patient where you just tick the category 1 box and wait for it to happen. And this is where what Kristine's saying about referral to a gastroenterologist is critical, because even within the category 1s, we kind of need to re-triage the category 1s, if that makes sense. So after COVID, a lot of the category 1s are actually almost at 3 months, which you know is very uncomfortable for all of us. So that's why we need to see them in clinic. We need to make an assessment about what is it, just one episode of blood on the toilet paper associated with no other symptoms, which is sometimes the case when we see PR bleeding referrals in clinic, or is it bleeding that is highly significant? Because those two, yes, they may both get a colonoscopy, but the timing matters, and it's very, very different. Sorry, Kristine.
No, that's all good.
Martina asked a question on the chat. I know it's 8:03, but we're going well with time.
No, it's fine, Gok. It was to do with that case because I couldn't put it on the Q&A.
I'm sorry, did I answer it as you went?
Yes, you did. You did. It's fine.
So
it's fine.
There's something on the Q&A though, from Philip. I had a patient with PR bleeding in their 40s. Her previous GP did an FOBT, which was negative. Then I saw her and referred her to a specialist, and colorectal cancer was found and Lynch syndrome. And it's an excellent point. Every test has their limitations, doesn't it? And all of us, that's why it's important to take that history and make that referral, even if the FOBT is negative, because every test has an error rate. And I think that's part of the reason, with Kristine's point there, that if they've got symptoms, then it's not really screening anymore. They need specialist assessment, which is why Kristine kind of, if they do come to her, she often refers them back to clinic to be seen if she feels that it's inappropriate for direct access. And this type of patient's a great example. One could argue rectal bleeding equals colonoscopy, but that's not always the case. Yes, in the ideal world, if you know it was an unlimited resource, then it may be, but we know it's a limited, valuable resource, and we need to make kind of triaging amongst triaging decisions. So not just the big categories, but even kind of fine-tuning that triaging to that really, really significant rectal bleeder that needs a colonoscopy. So yeah, it's a very valid point, Philip. I might leave the bacteremia one if that's okay. Kind of deviates a little bit from the talk, and then if we have time, I'm happy to answer it. 100% happy to answer it, because we're kind of running at 8:05, and I want to make sure there's a lot of time at the end for questions as well. So we're going to move away from family history and talk about polyp surveillance colonoscopy, essentially, and polyps. There's a question online. In the majority of cases, do you recommend a gastroscopy? So FOBT, the evidence around FOBT and gastroscopy is not as strong. FOBT is a good test for colorectal bleeding, but not necessarily upper gastrointestinal bleeding. And in patients with a family history of bowel cancer, we would generally, the evidence does not support automatically doing gastroscopy, and nor does it support automatically doing gastroscopy in someone who's FOBT positive. And really, I guess part of that is how common colorectal cancer is in our community versus gastric cancer. However, if you have an Asian patient who is from a high-risk area, and hence in our community, we have a very large proportion, as you know, of Asian patients, and they're from a high-risk area, then that's a case-by-case assessment, because again, there are no guidelines. You know, we've got beautiful guidelines Kristine showed you for colorectal cancer. No such clear guidelines exist for gastric cancer. So it's very much about case by case. I recently read an article that encouraged GPs not to dismiss, sorry. I read an article recently that encouraged GPs not to dismiss younger patients with symptoms like PR bleeding and recognize that younger patients can have colorectal cancer and often have their diagnosis delayed by 6 to 12 months because in a young patient, we aren't thinking about cancer. And it's a very, very valid point because we are seeing more younger colorectal cancers and we need to make that assessment on a case-by-case basis. And I know it's hard for you when you see a young patient with rectal bleeding or symptoms that are worrying. It's hard to know what to do, isn't it? And it's equally hard for us. And I think I use general principles with that and try and assess them in clinic and try and get, how much are they bleeding? What is the blood like? Is it just one episode on the toilet paper versus a repeated pattern? Has there been other patterns? Has it happened in the past before? A lot of things like that kind of come into, I guess, a more tailored approach. Because if we had unlimited resources, then a scattergun approach could work. But unfortunately, even the rectal bleeders, we need to know more about the rectal bleeding. Okay, there's been a big push and a change in polyp surveillance guidelines as well. And I'm going to talk you through some of the principles behind why the government made the changes they did and why the guidelines have changed the way they have. So the first principle to understand is that colorectal cancer develops from adenomas, full stop. Yeah, not all colorectal cancer. Inflammatory bowel disease associated colorectal cancer, that's a completely different pathway. But other colorectal cancer, most of them develop from adenomas. That progression from adenoma to colorectal cancer is usually more than a decade. That's the other point to kind of get in your head, is that in most cases, it's not like suddenly go from an 8mm adenoma to a colorectal cancer. It's usually longer than a decade, which might make more sense, which kind of guides a lot of the changes that have happened in the polyp surveillance guidelines. The other thing that's happened is there's been a nationwide, in fact, worldwide push on quality of colonoscopy rather than quantity of colonoscopy, i.e. is the bowel prep adequate? And if it's not adequate, it needs to be repeated, i.e. you cannot bill. MBS have come exactly onto that. If the bowel prep is inadequate for assessment of colorectal cancer, can't be billed as a colonoscopy. Full stop. And again, that push has been from the government as well as guidelines. There's been a very strong push on educating us about taking our time and making sure we pick up adenomas. So a very strong push on withdrawal times, which should take at least 7 minutes, not including polypectomy time. There's been a strong push on all of us detecting adenoma, keeping log of our adenoma detection rate. And a lot of us have been doing this for years. And for example, Michael Grimm and I have been doing it before it was mandatory. And we've kind of audited each other's adenoma detection rate for years before it became mandated 4 years ago. So now for recertification in colonoscopy, you have to show that you reach a certain adenoma detection rate. And if you don't, you're not recertified and you're not good enough to perform colonoscopy, essentially. So you have to reach a certain threshold of adenoma detection to be good enough. And the government have set that bar very low. Most of us, most gastroenterologists, most of our department run at about 50% adenoma detection rate. The government have set it at 25%, to give you an example of where they've set the bar, but there is a plan to push that bar up, which I think is sensible. And they've also, I'll come back to SSAs. So the whole push is really better colonoscopies performed less frequently. So the people with 1 to 2 low-risk adenomas, the new guidelines actually say 10 years, all right? Which is why you might see in some of Kristine's letters, 5 to 10, because it's a relatively soft transition because there needs to be some patient education around this big change to 10 years as well, because suddenly you might say to someone who's been having 3 yearly colonoscopies, oh, actually, no, you're not having your next one now to 10 years because the guidelines have changed. And that can be very hard for a patient to understand. The other thing for you to understand in primary care is, again, the MBS Medicare reimbursement for colonoscopy is directly tied to these guidelines, and hence the government won't pay for a colonoscopy outside of these guidelines. The other big push is the significance of these so-called cess-ulcerated adenomas, and if we have time at the end, I can show you some pictures, but these are the invisible ones, the dangerous ones that are so hard to see. And if you do a quick colonoscopy, you will miss them. And they're incredibly difficult to see, but they're the dangerous ones. And we all have to reach at least 4% of cess-ulcerated adenoma detection. And again, most of our department runs at around 18% for SSA detection rate, but the government set it at 4%. The MBS item codes are directly linked to those guidelines. So you can see where this is going. The reason for these new guidelines is to do better quality colonoscopy less frequently than we've been doing. Sorry, Kristine, long-winded. You're going to hate me for taking up time, but I thought understanding the principles before the next few slides was important.
Okay, so this particular slide and this resource can be found on the Cancer Council website. These tables were created using the clinical practice guidelines for surveillance colonoscopy, which were endorsed by the National Health and Medical Research Council. So like Gok mentioned earlier, the guidelines were designed to maximize the potential benefits of a colonoscopy. So placing a lot of the emphasis on a good quality colonoscopy at appropriate intervals, but they should also be used to support clinical judgment and should only really be used after a good quality colonoscopy has been performed, where all the significant polyps have been removed. Now, the main principles of surveillance here based on the findings of the index colonoscopy. So we do need to consider the type of polyps that were found. This means that we need to know the histopathology of the polyps first before recommending any surveillance. Because not all polyps require surveillance, such as some hyperplastic polyps. So we have table A, which looks at all the conventional adenomas, tubular tubulovillous adenomas. B looks at the significant serrated polyps and cess-ulcerated adenomas. And table C looks at a combination of both. Now, another factor that we do look at is the number of polyps. So depending on how many polyps a patient has removed will determine the time frame. So whether it be 5 to 10 years, 3 years, or 1 year. Another key component is the size of the polyp. So the larger the polyp removed means shorter surveillance interval. So we can see on table A, even having one conventional polyp larger than 10 millimeters in size can be the difference between having surveillance done at 3 years' time or having surveillance done in 10 years. And lastly, we also need to consider the presence of any high-risk features. So looking at any dysplasia or velocity. So if these features are present in the polyp, we can expect a shorter surveillance interval, which is generally between 1 to 3 years.
Kristine, there's an excellent question online, which we might just quickly answer now. SSAs it's about. So these are the serrated polyps that you can see on table C and table B, essentially. So serrated polyps are often right-sided. They're less obstructive, which is often the case. And for us, one of our teachings is they often have this mucus cap and they're often not ulcerated, and hence they don't often bleed. So the question is very valid, is how effective is FOBT in picking up SSAs? And the answer to that, unfortunately, is not very good. And hence, why a good quality colonoscopy is so important for that particular type of polyp. They are invisible and very, very, very hard to see. The other point about this table is just if you think about what's an advanced adenoma, is essentially presence of high-grade dysplasia, a villus component, or 10 millimeters in size. We don't need you to know that. We don't need you to know this table. Like Kristine and I have an app that we use rather than this table. So if a patient says to you, oh, Dr. Pavan randomly went into this app on his phone and then came out with a number of 1 year versus 3 years, it would be this. Unfortunately, that app was created by a clinician, not the Cancer Council, which is why we can't just widely share it, unfortunately. I'd love to. Kristine and I thought about putting the link in this talk, but it wasn't created by the Cancer Council. It was created by a clinician, and it says specifically on the app, this was created by a clinician using these guidelines. It's for use in this setting, etc. But it's easy to find. If you Google Cancer Council polyp surveillance app, you probably find it, but we just can't put it into the talk because it's not put out by the Cancer Council. Sorry.
All good. And so this slide obviously looks very overwhelming, but again, for the second colonoscopy or the subsequent colonoscopies, we do look at the same principles. So shorter surveillance intervals for high-risk findings, and for normal or low-risk findings, we can extend the surveillance interval or go back to FOBT screening, and even consider stopping screening and stopping surveillance altogether. But that is based on the individual, and we will discuss that a little bit later on after this last case study.
So this table is way too complicated for you guys to try and learn because it's less relevant. It's something we use, and the app does it automatically for us. We put in what was found at the first colonoscopy, then we put in what was found at the second colonoscopy, and then it comes out with a number, essentially based on this. So this is what Kristine showed you first was the first colonoscopy. This is the second colonoscopy. Is this me? It is.
Yeah.
Sorry, that's why you're silent. Mr. SM, another real case from something we've looked after, presents for polyp surveillance, but also has had long-standing diarrhea. So note, this is not a change in bowel habit. This is long-standing diarrhea, which is probably less relevant in terms of cancer versus a change in bowel habit. Last colonoscopy 2018. The findings of that colonoscopy were 4 7 to 9 millimeter tubular adenomas with low-grade dysplasia. So remember, 10 was one of the numbers to remember, high-grade dysplasia and villus component. So actually it doesn't have any of those three things. Let's move to the next slide, which talks through. So what do you think? Where does he fit? It is a man, isn't it? Yeah, 73-year-old man. So he had 4 colonoscopies, 4 polyps, all of which were under 10 millimeters. So someone put into the chat where this person might fit, when their next colonoscopy should be. So 4 adenomas, and they're all conventional, so no SSAs. Excellent. None of them are, so essentially this is a non-advanced adenoma. So if you have one of those features, either 10 millimeters in size, high-grade dysplasia, or a villus component, i.e. a tubulovillus adenoma, then you go into that right-hand column. But this guy has 4 polyps, so he's in the 3 to 4 category, and he has no high-grade velocity or villus component. So yes, you're right. 5 yearly, which is now. So he was 2018, so he's due now. Excellent. Everyone, there's like a whole series of 5 years, 5 years, 5 years, Kristine, because you can't see the Q&A. So everyone's on the money with that. This is an important topic, and I've talked about this before as well in GP talks, and I think it's the next slide, Kristine. It's a very, very, very difficult balance. And that's the question of when to stop surveillance. So the government guidelines around polyp surveillance, as you saw, was actually a bit earlier than I think in 2023, with people living longer. then we should. But I think it said 74, didn't it? The government guidelines. And that's around the time they stopped FOBT screening as well. But all of us know that there are robust, exceptionally healthy 78-year-olds that are very likely to live another 10, 15, maybe even longer. So that's why it needs to be case by case. Kay, do you want to talk to this, or do you want me to talk to this?
You can.
And please stop me and add anything. This was a slide you wanted to include, and I think it's really, really, really important. So please just jump in anytime, and same with the audience. The older you are, the riskier your colonoscopy. So don't underestimate the anesthetic risk. So although it's so-called conscious sedation or twilight sedation, it's still propofol. So it's still a drug that causes profound vasodilatation, drops your breathing, drops your blood pressure. For example, someone with severe AS is an anesthetic nightmare, because you can imagine as soon as you vasodilate, the AS gradient gets really massively enlarged and they can arrest very quickly. So the nature and type of comorbidities is important. And don't think of anesthetic for colonoscopy as, oh, it's just twilight sedation, because it's still the same drug and it's just different gradations of that drug. They might not be so knocked out that they can't breathe for themselves and intubated, etc., but they're still receiving a drug that will have significant impact. So it'll depend on their comorbidities, it'll depend on their age, it'll depend on their overall health and also their prognosis. So if someone had an excellent clear colonoscopy at the age of 75, and now they're 79, and they have heaps of comorbidities, some of which may mean their prognosis is less than 5 years. That's the type of person you don't want to just be doing routine colonoscopy on, because you're not going to provide them adequate benefit to justify the risk. Does that make sense? Because if they're going to die from something else before an adenoma forms, because you know the 75-year-old colonoscopy was clear, or the colonoscopy 4 years ago, or even the colonoscopy 6 years ago was free of adenomas, by the time a new adenoma forms and then becomes a cancer, some other condition may determine their prognosis more than this. And that's when your risk of colonoscopy starts to outweigh the benefit. So even a clear colonoscopy 6 years ago is important, but importantly, good quality colonoscopy. Did they get to the ileum? Did they have good bowel prep? And was it a good quality look for polyps? Oh, excellent question. I've had several colonoscopies without sedation, i.e. live, and didn't find it at all uncomfortable. Absolutely. So I've done unsedated colonoscopy on patients, and they're often medical. That's kind of talked about here. And you're right, it can be tolerated, but that's very much case by case, isn't it? So that's not without discussion, an unsedated colonoscopy, but sometimes the stress or pain of the procedure can, if they've got ischemic heart disease, then can put their heart rate up. And I think that has to be case by case, the unsedated colonoscopy. What is the incidence or risk of bowel perforation is very, very low. So the old data used to say less than 1 in 1,000. To be honest, in practice at a high quality center, high volume center, it's significantly lower than that. Unfortunately, there's not new data that's kind of pushed that number down, but anecdotally, that number is much, much, much lower than 1 in 1,000. So yeah, we really wanted to make sure that we talked about there is an age when you should stop surveillance and what things come into it. Go, Kristine, you've got to talk about statewide referral.
Yes. So I thought I would use this session as an opportunity to very briefly promote the statewide referral criteria that is being rolled out by the Ministry of Health for New South Wales outpatient services. So there's currently some new criteria for some selected conditions within gastroenterology. We're continuing to develop this over the next few years, and this is also going to be developed for other specialties in the near future, but gastro and ophthalmology just so happens to be one of the first. So for some context, statewide referral criteria SRC, it is a clinical decision support tool that promotes consistency and transparency to identify patients suitable to access outpatient services. So essentially, it is a tool that will provide the minimum criteria and referral information to provide a good quality referral, which will then enable safe, timely, and efficient triaging. So SRC has been developed and implemented in other Australian states, including Queensland, Victoria, and Western Australia. And the research shows that SRC does improve referral quality and appropriateness, reduces complexity to refer to outpatient services, and increases the equity of access. So some of the benefits for patients and the outpatient services include improved safety through appropriate prioritization from referrals containing all the required information for triaging. So by having a more streamlined process, and also it improves the safety and increased efficiency of the triaging. A reduction in unnecessary wait times on outpatient wait lists, increased equity of access through greater transparency and consistency with referral acceptance and triaging, and ready for care at their initial consultation. So on our end, this means minimized multiple clinic appointments, as the patient should really be attending their initial consultation with all the appropriate investigations and information. So some of the benefits for the referrers: support with clinical decision-making to issue referrals to a public specialist outpatient service. So as the referrers, you will be able to refer to the SRC to determine if a patient's clinical condition is an emergency, if it's out of scope for the gastro specialty, or the urgency of the presentation. So we'll have Cat 1, which is 30 days, Category 2 to be seen within 90 days, and Category 3 is 365 days. There will be some clear expectations of clinical and referral requirements. So this refers to the SRC really detailing the mandatory information and investigations that need to be supplied with the referrals. So having these referral requirements really will be able to support the triaging process and be able to determine the urgency of the referral. And a reduction in the volume of referral returns due to inappropriateness and missing information. So I'm sure that many of you have received some correspondence from us saying that certain referrals have been deemed as insufficient. So by having these referral requirements, this can be used as a guide to ensure that you are providing us with all the appropriate diagnostics and pathology, and will give us a good quality referral, which means efficient triaging and shorter wait times for the patients to their clinic appointment. So that was just a very brief rundown of the SRC for gastroenterology. This QR code will lead you to the government website where you can view the gastro SRC and the ophthalmology SRC. There's also some additional information on there, other links to frequently asked questions and fact sheets and other resources. This is the list of presenting conditions that are currently out for gastro. And like we mentioned earlier, there is no go live date at the moment for the SRC at St George. So we are very slowly implementing the criteria and the triage categories. We've adapted our local guidelines to be aligned with the SRC. There is no go live date yet, but we would really encourage that you do refer to the SRC and use it as a guide to refer to our gastro service. And also please feel free to provide some feedback around this. I think the QR code also leads to the SRC project email, and they are very keen to hear back from you guys.
So the principle behind that is very much there. It's a limited resource, as most of you know, and there are this many people being referred to the clinic, and what we don't want is to miss the really sick patient, and hence the government is trying statewide to set some criteria around referrals, both what should be in it and also what conditions should be seen at a tertiary level specialist referral practice. And they are also, just as a word of warning, they are also going to have a not in the scope of specialist tertiary level outpatient referral category as well. So they are going to list some things that are deemed not suitable or shouldn't be seen in a tertiary level public hospital clinic, and then you know that those are the kind of lower risk patients that are often referred to our clinics and other New South Wales clinics everywhere. This is not a problem unique to us. Most of you know that. Sorry, Kristine, I just wanted to.
No, that's okay. So and SRC is going to be rolled out statewide, and it's going to be mandatory for all outpatient services, and not just gastro, but all the other specialties as well. So even though it hasn't gone live yet at St George or Southeastern, it very well might have gone live already at some other hospitals. And how to contact us. So gastrohepatology department, we have a number of CNCs. The best way to contact us is via our department email, but I also have listed all of our CNCs for liver service, for direct access and IBD.
Sorry, we've cut you short of time for questions, but we're happy to stay on if that's allowed to answer questions. Oh, sorry, Kristine, I've even gone one step ruder. I've cut you off. Sorry, you go.
That's okay. Just one more. So how to refer to direct access colonoscopy. So when direct access colonoscopy was initially designed to fast track FOBTs to the colonoscopies, but we also are accepting referrals for polyp surveillance and family history. So this referral, you can find it on Health Pathways, but it also has previously been circulated through PHN newsletters and even directly to your practices. And lastly, so direct access colonoscopy referral pathway you can find through the clinical pathway for positive FOBTs. There's also a list of other conditions and it can lead you to the referral pathways for all of our services. So gastro clinic, liver clinic, IBD, and swallow and motility as well.
There was a question.
I think that's it.
There was a question about when are those guidelines for colonoscopy effective? Those guidelines came out about 4 years ago, and the link to the MBS provider number also, MBS item number also 4 years ago, roughly around the same time. So you might have seen us rejecting some polyp surveillance kind of referrals. So the patients come to see either Kristine or I, but they don't fall into the new guidelines. They're completely asymptomatic and they feel completely well. It's just that their old proceduralist had told them they need 1 in 3 years or whatever number. But now from this point forward, these are the guidelines and this is what the government's willing to pay for. And hence we're really sorry, but this is what the guidelines say. This is when you should have your colonoscopy. And also for your knowledge, it's linked to what the government will pay. And Martina, you are welcome to say something. Please fire away.
Thanks very much, Gok and Kristine. I just wanted to let people know that Health Pathways has the statewide referral criteria in draft, and we're just waiting for the public hospital outpatients to tell us when they're going to start applying them. And as soon as we get the tick from you guys, they'll be live on Health Pathways for our users. And also we've got a broken link for the referral form for you guys at the moment, but we are hastily getting Streamline as our technical writers to fix that up. So there is a colonoscopy referral page that has the direct access colonoscopy information, and we should have that particular referral page ready for people within the week. We didn't realize the PHN's taken the link down, and so we've had to do a quick fix. But yeah, just those things about pathways.
There's a question in the Q&A about whether we see patients from other areas. Unfortunately, our clinic is so flooded with referrals. So our patient department, who you know run all the clinics, constantly tell us we're getting the most referrals, and we've had to say no to out of area very, very strictly in terms of our clinic. So and that's to protect the well-being of the patients in our area. And again, the general principle of clinic triaging is not to miss the sick patient in the very much the massive volumes we get. And that's why the statewide criteria have come in across the state as well, with that same principle in mind, not to miss the very, very sick patient amongst all these referrals that are flooding gastroenterology clinics statewide. And that's why the out of scope column is going to be there as well, so that these are the types of patients that shouldn't be referred to a tertiary level gastroenterology clinic. And as most of you know, there are 1,000 private gastroenterologists around who can see those guys, and the clinic should be reserved for people who absolutely need tertiary level care and can't afford it anywhere else. Is Sutherlandshire considered out of area? So Sutherland patients, we've pushed Sutherland to set up a gastroenterology clinic. They have. It's just not as well known as our clinic. Kristine, is that a fair statement?
Yeah. Sutherland Hospital do also have a direct access colonoscopy pathway and
also a clinic. So that's where those patients should go, because again, otherwise we're at risk of missing the very sick patient that needs an urgent clinic appointment. Is colonoscopy indicated to evaluate unexplained iron deficiency anemia? Absolutely is. And it is one of the referral criteria. And for us, it's one of the category 1 criteria because it can be cancer. So unexplained iron deficiency, particularly if it's not a menstruating woman, is definitely, i.e., I should put it another way, unless there's another explanation for the iron deficiency or severity of iron deficiency, then they should definitely be seen in clinic.
And the SRC goes into quite a bit of detail around that. That is one of the indications that has been released in the SRC. So
it's not appearing in the health pathways, Daisy, but it is definitely, iron deficiency is definitely a referral criteria. It may not appear in this kind of health pathways because most of you know what to do with that. So the health pathways are kind of there to help guide you, but it's a very valid point though. We should put, it should be in this list as well. Daisy's right. It should be in this list, but it's definitely in the SRC list. The statewide referral criteria, risk of folate supplementation above 1 milligram data. Look, not much data for or against. I'm kind of neither here nor there with folate supplementation outside of folate deficiency or methotrexate use. The reason that patients go to outpatients is more than more that yeah, absolutely. So the reasons that patients go to outpatient clinic is that they can't afford private gastroenterologists. 100% agree. But unfortunately, across the state, there just isn't the resources to see every single patient that's referred, and hence why triaging exists. And then the SRC criteria of these are the types of patients and conditions that should be reserved in this clinic. And then we need, as a profession, as a group of specialists, we need to be able to help you manage that patient that is out of scope, but you need help managing, and they can't afford to see someone privately. That's when health pathways can be really, really helpful. For example, constipation management, even celiac disease management in general practice. So health pathways can be helpful, and kind of upskilling all of you in managing those things that we don't necessarily want to take away appointments from someone that desperately needs it. Yeah, so what can we do for poor pensioners and poor patients? Yeah, if they need to be seen, the SRC criteria will still get them seen. It's not that they're not going to be seen, and it's not that they're not going to get their scope. If they fit criteria for needing a colonoscopy, then they will be seen in clinic. There will never be a time where the SRC, I hope, in my time anyway, or I hope never, that in Australia, you won't be able to access good quality healthcare without having to pay for it. I don't think that'll happen, and that's certainly not the intention of the statewide referral guidelines. And I can't see it happening, if that makes sense. So if they need a scope and they fit criteria for a scope, then they will be seen and they will get a scope. Yeah, you're right. And then abdominal pain is the really hard one, isn't it? So a comment about abdominal pain, which sometimes can be something minimal and sometimes it can be something serious. And you're absolutely right. And all of us are going to show discretion. When Kristine and I said when the government mandates this, yes, we're going to use it, but there will still be a degree of leniency and discussion around it. And you know, if you're worried about your patient, I think the simple rule is just pick up the phone and speak to us. And you're right, abdominal pain is one of the really hard ones. And I think rectal bleeding can be hard as well for reasons highlighted by people on the Q&A. You know, sometimes it's nothing, but the one time it's cancer, you don't want to be dismissing it. And that's why all our jobs are difficult, aren't they? Particularly your job, because you're seeing all of them first before we are. And you know, I completely appreciate that kind of weeding out the minor symptoms from the more significant ones is incredibly difficult. And I think it's our job to help support you with that. So please just pick up the phone and speak to us if you're not sure. Should this patient be referred? I'm not sure. Just pick up the phone and speak to us and we'll help you make that decision, and at least share the responsibility, because it can be sometimes very difficult. What age do you take and do colonoscopies on iron deficient patients? Do you want celiac serology? Yeah, good question. What age do you take and do colonoscopies? So look, if it's a lady who's young person who's menstruating and the menstrual periods are large enough in volume to explain a degree of iron deficiency together with diet, then we may say, let's not see them. But if that decision's too hard for you to make, send them to us and we'll help you make that decision. Do we want celiac serology or duodenal biopsies first? Happy for you to do celiac serology. One test I'll make a point about that is not useful, and I see ordered all the time, is the HLA-DQ2 and DQ8 genetic test. So super useful when it's negative, okay? So the celiac genetics or the celiac genetic tests, 99% accurate when it's negative. So it's super useful to exclude the low-risk patient. But when it's positive, completely useless. Its positive predictive value is around 40%. So it's completely useless. So patients often come to us with, oh, I've got celiac disease, my genetics are positive. Well, that's not the case. So the genetics have a very high negative predictive value, but a lot of the normal healthy population are positive. But please, if you want to do serology, do it. Do serology first. But the key ones are TTG, IgA, and IgG. So the anti-tissue transglutaminase, and particularly the IgA. Deaminated gliadin, IgA and IgG. And again, IgA trumps IgG. And please always do a total IgA level, because celiac disease is associated with IgA deficiency. Last question, I think we should, because it's almost 8:50. If you can't see actively bleeding hemorrhoids, but a history of red rectal bleeding and a normal PR, do they need a scope or an office sigmoidoscopy? So excellent question, and it really depends a bit on their age and the type of bleeding, volume, amount, paper versus blood, mixed versus separate, and could they have an office sigmoidoscopy? So a lot of colorectal surgeons can do rigid sigmoidoscopy in the office. A lot of us are trained to do that, so but choose not to do it in the office because of complication risk. There's still a risk of complications there. So that patient, I think if you're not sure, refer. All right, we should wrap up. I think it's well over time, and I'm sure people are hungry. We're sorry we tried to stick to time. Bertha, Jan and Martina and Kylie, we went well over time, didn't we? Sorry about that.
It was very fascinating and lots of questions for you. Thank you so much for your time, Dr. Pavan and Kristine. Very interactive, and obviously there was a lot of questions and lots of information on the new guidelines and everything. So we'll send out resources in the next couple of days, along with the evaluation survey. So again, thank you everybody for joining us tonight. We'll see you next month. And thank you again to our speakers and Martina in the background. Thank you very much, everyone. Good night.
Thanks very much.
Thank you.